I'm going to present on a topic superior venecava syndrome. Superior venecava syndrome, it is a constellation of signs and symptoms due to obstruction of blood flow through superior vena cava that causes impairment of venous drainage from head, neck, upper limbs, and thorax. This picture shows superior vena cava, which is formed by the confluence of right and left brachiocephalic vein. Pathophysiology that it includes the increased venous pressure due to retrograde blood flow that causes venous congestion, edema, reduced cerebral venous drainage. The severity depends upon the rate of obstruction and collateral development. This picture shows superior vena cava syndrome. In here, the superior vena cava is been compressed by a malignant lesion in the right lung. The causes are malignant causes which contribute to 85 to 90%. Among lung cancer, non-small cell lung cancer accounts for 50% and small cell lung cancer accounts for 25 to 35%. In lymphoma, non-Hodgkin lymphoma accounts for 10 to 15%. Other causes are metastatic mediastinal disease such as breast cancer, germ cell tumors, thyroid malignancy. Non-malignant causes are thrombosis that can be caused by CVP catheters, hemodialysis, and its catheter, pacemaker leads. It can also be caused by fibrosing mediastinitis, which can be due to infectious causes like histoplasmosis, tuberculosis. It can also be due to aortic pathology such as aortic aneurysm of ascending aorta. Rare causes are Behçet's disease, radiation-induced fibrosis, and sarcoidosis. Overall, common cause is due to malignancy related, that is lung cancer, and the most common non-malignant cause is catheter-related thrombosis. The patient presents with the symptoms such as facial and limb swelling that exacerbate on bending forward, and also patient present with cough, dyspnea, headache, visual disturbances, and dysphagia also. The sign we can see in patient are facial plethora, neck vein distension, dilated chest wall vein, dilated abdominal wall veins, upper limb edema, cyanosis. In case of malignancy in thoracic inlet region, it is associated with Pemberton sign, that is by raising both hands near to air, it causes facial plethora and distant facial swelling and redness of face. Features of myasthenia gravis can be also associated with the thymoma. Lambert-Eaton syndrome is associated with small cell lung carcinoma, in which there are proximal muscle weakness. This is a picture showing the different collaterals due to different site of obstruction. When there is obstruction above the azygous vein, entry of azygous vein, the collaterals are seen dilated in the anterior part of chest due to the communication of vessels from lateral side of scapula to intercostal veins. In below azygous vein, if there is obstruction, the venous veins are dilated um, in the abdominal region due to the dilatation of the thoracoepigastric junction veins. This is a picture showing metastatic syndrome. Here, the patient is the plethoric. There is puffiness of eyelid, and there is also a congestion in the face and dilated veins in chest wall. Stridor, altered sensorium, and hemodynamic compromise are the red flag signs. Grading of SVC syndrome in malignancy can be grade 0. In there is only radiographic evidence, but the patient is not symptomatic. In grade 1, there is edema of head or neck, there is vascular distension, and the patient shows cyanosis and plethora. Grade 2, there is edema of head, neck with functional impairment also, with mild dysphagia, cough, mild or moderate impairment of head, jaw movement, and visual disturbances due to eyelid edema. In grade 3, there is also additional features such as headache due to cerebral edema. There is mild to moderate laryngeal edema, diminished cardiac reserve that causes also syncope. In grade 4, there is substantial cerebral edema that causes confusion and often sedation. Or laryngeal is edema that which causes severe enough to cause stridor, and the hemodynamic compromise causes syncope without precipitating factor, other precipitating factors such as hypotension, renal insufficiency. Yesterday's patient was of grade 3, in which patient was suffering from syncope while bending, and there was also edema in the face, and the patient was suffering from dyspnea from the last week also. SBC syndrome related to lung cancer. In most of the patients, 60% of the patients present for the first time with SBC syndrome who are not diagnosed before with lung cancer. 60% accounts for non-small cell carcinoma, and 25 to 35% accounts for small cell lung carcinoma. And 2 to 4% of patients with the cancer develop SVC syndrome. Most common with squamous cell lung cancer, that is 10% of patients among 10% among small cell lung cancer, and 2% among non-small lung cell cancer. But the incidence of non-small cell cancer is more, so the number of patients with SVC found is more. We can see more in non-small cell lung cancer. It can be caused by direct invasion of the tumor into SVC or by external compression involving the lymph node and other metastatic structures. External compression and thrombosis may also coexist. Diagnosis gold standard is CT chest. It helps to identify the site of obstruction. It can also identify the cause, whether it's a mass or thrombus. It also helps to identify the presence of collateral vessel, which is a strong indicator with a specificity of 96% and sensitivity of 92%. It also helps to identify the level and extent of venous obstruction. It is critical for planning endovenous intervention. License smell this slide. Sorry, this was a slide video showing the city chest. There was a right-sided long malignancy that compressed superior vena cava. This part shows the clot. Another cause of superior vena cava syndrome due to clot, that is a clot hypodense area. The cap, there is a clot. And other investigation we can do is duplex ultrasound. It is used to exclude the thrombus in subclavian, axillary, and brachiocephalic vein. MRI, it is an alternative to CT chest if the contrast is to be avoided in case of renal involvement. CT venography, it helps to in detail venous. It helps to detect the detailed venous anatomy and the exact level of obstruction. Uh, I also want to discuss a radiological staging in between. And this is Stanford classification. In type 1, this picture shows type 1, type 2, and type 3, and type 4. In type 1, there is a mild SVC obstruction. There is a mild SVC obstruction with vessel obstruction of less than 90%. In type 2, the stenosis is of 90 to 100%. In type 3, there is a complete SVC obstruction with prominent blood flow through collateral veins, but without involvement of mammary and epigastric vein. In type 4 Stanford, there is the involvement of collaterals, and the mammary and epigastric vein is also involved. The other investigations are tissue diagnosis by bronchoscopy guided or CT guided or lymph node biopsy. Other important investigation are chest X-rays, sputum cytology, pleural fluid cytology. We can and CBC coagulation studies to see PTINR hypercoagulability workup can also be done. Tumor markers such as uh, SCG, alpha fetoprotein for patient with germ cell tumor for monitoring can also be done. Bone marrow biopsy in case of for both diagnostic and staging of patient for suspected non-Hodgkin lymphoma or small cell lung cancer. Now talking about the treatment, starting from general approach. First a patient comes, then we have to see if there is thrombus also. If the patient is symptomatic with grade 3 or grade 4 symptom, such as associated with cerebral edema, laryngeal edema, or hemodynamic compromise. If these symptoms are present, then If the thrombus is present, we will first anticoagulate, then we will secure the airway and hemodynamic stabilization is done. If And we will be doing urgent endovenous intervention. If these features are not present, we have to see if the patient has already been histologically diagnosed. If it if is the case of if the tumor is sensitive to systemic therapy, then we will first proceed for systemic therapy. Then, if it doesn't resolve, then proceed to intravenous intervention or other therapy. If the patient has is if the tumor is non chemosensitive, less chemosensitive, such as non-small cell lung carcinoma, then endovascular intervention is first preferred, then followed by radiotherapy or multimodal therapy. If the patient has no histologic cancer diagnosis, then individualize the decision for intravenous intervention before stabilizing the diagnosis if the as the symptoms will be severe, then followed by further workup. Intravenous intervention, it can be handling with thrombus or stenting on the vessel. In thrombus handling, the thrombus burden is to be decreased by thrombectomy or thrombolysis that can reduce that can also reduce stent number and length. When bleeding risk is high, mechanical thrombectomy alone is preferred. Stenting, technical success of stenting is 95 to 100%. Over 90% of patients experience symptom relief. Stenting is performed particularly via jugular, basilic or brachial vein or femoral vein under local anesthesia and sedation. A guide wire crosses the obstruction and stent is deployed, often after predilation with angioplasty. Heparin bolus 3,000 to 5,000 unit is commonly given. Yesterday also we gave the patient about 5,000 unit of unfractionated heparin before the stent placement. If both brachiocephalic veins are obstructed, then parallel kissing stent plus an IVC stent may be required. This is a picture of venogram that shows tight stenosis before stent placement and after stent placement. In first picture, there is obstruction of SVC here with along with prominent azygous vein. After stenting, the second picture shows the recanalization of the SVC along with the disappearance of less prominent azygous vein. The few complication of stenting can be it includes bleeding, embolism, stent migration or occlusion. With larger stent, it is linked with high risks with larger stent. Post procedure antithrombotic therapy is also recommended. This picture shows venous stent, whether to use and how to give anticoagulant or thrombotic drugs after a venous stent placed. If the venous stent is placed, then we should load a clopidogrel 300 mg orally once immediately after stent placement. If the lesion was thrombotic, then we should initiate therapeutic anticoagulant if not done already. Then we should continue clopidogrel 75 mg for 90 days. After completion of clopidogrel for 90 days, then followed by uh, aspirin orally once daily. If uh, if there's no thrombus, then continue clopidogrel only for 90 days, then and followed by aspirin. If only angioplasty was done, if there is no stenting place, only angioplasty done, or for example dilation with balloon, then if then we have to see if there is thrombus, then we give aspirin once orally daily, and if there is no thrombus, then aspirin once daily will be continued with or without clopidogrel. If the lesion is not thrombotic and we have not done angioplasty, then no intervention is required. For radiotherapy sensitive tumors, radiotherapy, it can relieve symptom often within 72 hours, and complete relief in 63 to 78% of lung cancer is seen. However, benefit delayed, temporary or due to collateralization, and 20% gain no relief. Stenting provides faster palliation and is preferred over urgent radiotherapy and remains effective even when radiotherapy fails. Chemosensitive tumor. For chemotherapy sensitive tumor malignancies such as small cell lung cancer, non-Hodgkin lymphoma, and germ cell tumors, initial chemotherapy is preferred with rapid symptom relief and potential for long-term remission. Symptom improvement usually occurs within 1 to 2 weeks, with 77% response in small cell lung cancer through relapse, though relapse may occur. Radiotherapy alone gives poor long-term, so combined with chemotherapy. In heavily pretreated patients, stenting or radiotherapy may be needed for palliation when chemotherapy fails. Surgical resection and venous reconstruction. In case of thymoma and thymic carcinoma, surgery is preferred. Surgery with SVC reconstruction is rarely done because it will be risky in this case. Surgical bypass can also be done in patients with leftover germ cell tumors. Other supportive treatment can be positioning of the patient with head elevation to reduce pressure and swelling, elevate affected limbs to lessen edema. Catheter IV management. If the obstruction is due to catheter-related thrombus, then we should remove the device. Fluid management. Overhydration should be avoided. Diuretics may be carefully used if there is benefit, but it's not usually recommended. Glucocorticoid, it is helpful in emergency radiotherapy for area obstruction. If there is area obstruction in case of severe cases and case of lymphoma, we can give steroid. It is not recommended in case of lung cancer until and unless there are airway edema. In management, this is a similar management as per National Comprehensive Cancer Network, an American Society of Medicine and Oncology, and American Chest Physician Society. In severe, it can be various based on various different topics, such as it can be based on severity. It can be based on the type of causes. In severity based treatment, in case of life-threatening case, first line will be immediate endovascular stenting, which causes decompression within 24 to 72 hours. We also give the supportive therapy such as dexamethasone for airway inflammation and oxygen supplementation, and we should protect the airway, and hemodynamic stability should also be maintained. In severe case, but when the case is stable, all the patient presents with marked facial edema, dyspnea without airway compromise. The management includes stenting. Stenting is preferred, but tumor-directed therapy if diagnosis is already been done. In mild to moderate case, no airway or neurologic compromise, management is via the opt-in. The tissue is first tissue diagnosis is made, and then chemotherapy or radiotherapy on the basis of diagnosis of the tissue diagnosis. Etiology-based treatment, malignant SBC syndrome. It is a common cause, 85 to 90% cause. Chemotherapy for chemosensitive tumors, radiotherapy for non-chemosensitive tumors such as non-small cell lung carcinoma, and in case of palliative. Endovascular stenting for severe symptoms or in cases with recurrence after chemo or radiation, or when patient needs rapid relief. In case of thrombotic cause, that is only thrombotic cause, non-malignant SPC syndrome, uh, after removal of catheter, anticoagulation treatment is given for 3 months. If catheter is retained, then until the catheter removed plus 3 months is given. In case of malignant associated, we can give indefinite treatment or more than 3 to 6 months also. We can do thrombolysis with alteplase for acute thrombosis, that is of cases within 14 days. Device removal should be done, and stenting for persistent obstruction despite anticoagulation. Role of adjunctive drugs such as corticosteroid, it is limited to the cause such as lymphoma and when there is significant airway edema. And diuretics, it is not routinely indicated, but we can give with close monitoring. Some of the differential diagnoses can be congestive cardiac failure and Cushing syndrome. Thank you.
Thank you, Dr. Reju. So, first of all, we talked about this SPC syndrome. We want to comment especially Dr. Mohammed that we started yesterday. The first case done by surgeon in our hospital, the SPC stenting. It was done successfully in the operation school. So therefore, thereafter, we wanted to hear from Dr. Reju what is written about the SPC obstruction. So, some diagnosis is said very correctly that it's most common cause is the malignancy. 60 to 70% is what the malignancy, 60%, especially the lung cancer. Then comes the various tumors and things or lymphoma. The next cause is because very common to the CVD catheterization or some pacemakers, some cannulations because of this, cannulations because of this hemodialysis catheter. This may also cause phenomenon of the SPC syndrome. So quite very important is to say that we need classification for that. So I want to highlight the signals and two classifications. It's very important for the clinical. So she said that what is the clinical classification depending on this degree of the stenosis of this species obstruction. She said 0, 1, 2, 3, 4, 5, or 1 to 5, sorry. So if that signifies that if somebody is not very symptomatic, or means it falls in 1 to 3 grade, there is no necessity for a severe patient. We can directly start with the treatment of the primary indications for the obstruction. If is a stage degree is stage 4 or 5, then when the preferred choice of the step being followed by the treatment of primary. Is it correct?
Okay.
That remains. This is the one. The second very important for the intervention is like we do yesterday is measure where is the location of the tumor, or where is the location of the stenosis or stricture, which is causing the obstructions. So from that point of view, the Stanford OT classification that divides into the four steps. So my slide clear, sir, that four group that she mentioned. So what is very clear that if something which depends upon the insertion of the azygous vein, this is if something is like above that, particularly this inhuman veins, extending into the superior because there is a great stage one. If it is located at the just up to the azygous, subsequent is according to the second type of the second type of the as we said, if it is in very totally at the position where the azygous vein is trading in place, you see, that is the type 3. That is more fatal for the patient. That is more complicated than other variants. And the type 4 is distributed infraazygous, below the intestine. These are the four types according to the Stanford classification. The most important factor for the patient is type 3, where this not only the SPC but also the azygous vein inserts is blocked. Therefore, it compromises the collaterals. That is for the patient. In the previous one, let's suppose the tumor is located at the or the whatever the stenosis at the level of the azygous vein. So skewing. So what could be the potential collaterals?
Azygous pathway is blocked, sir.
Block, sir, because it has completely blocked. Then what could the possible collaterals? Nothing will just as it is very good. Internal damage.
सबक्लेभिनको ब्रान्चेस के अरे ट्रिब्युटरी अनि ग्रेट सेफिनस भेन सम इन्फेरियर भेन
degree of stenosis. Mild, moderate, severe, very severe. There is different in this also. 100% of so 40% also there. So next very important things as you mentioned, yeah, the clinical courses. Do we always need to take the patient first thing? The first thing that it signifies is if it is stage 1 to 3, no need to treat the primary entity. The stage 3 and second very important thing should be considered whether the clot is there or not. When I turn down the intestinal class, if there is the thrombosis, then before doing the stenting, we have to remove the thrombus. There is a bonus of some embolization, where to therefore there are no person likely you should have some discussion to retrieve the thrombus. Thrombus पर निकालने को सबै डिभाइस गरेर निकाल्नु छ थ्रोम्बस सर्ट अफ थ्रोम्बस आर्सेल त्यसले क्याच गरेर बाहिर निकाल्नको चाहिन्छ किनकि नेभर नो the compounded thrombosis could be two just not only the external compression the thrombus component also. So for that, we have to anticoagulate the patient. We have to insert the catheter to the local thrombolysis also. So I'm not quite sure antiplatelet have levels inside. Sarkisai,
Yeah.
classical strophokinases versus glucokinase versus
अहिलेको त
antiplatelet
न्युरो सेन्टरहरूमा त इमर्जेन्सीमा स्ट्रोकको पेसेन्टहरूलाई चाहिँ गरिरहेको हुन्छ
यो पनि सोचेर गर्ने आधारले गर्ने के त हामीलाई अबको लागि चाहिँ पनि सोच्ने थ्रोम्बोसिस should be excluded if there is a thrombus component. Then we can proceed, but with the functional and first insert catheter locally thrombolyze it or if it's another part. Thrombus doesn't proceed to the stent. Third thing मैले के बुझ्यो भने अर्को बारे चाहिँ कि biopsy जहाँनिर पछि biopsy when do you take the biopsy? Without before taking about 20 years ago, when the patient comes to this, no need the biopsy. I'm told the book like is the emergency situation, no need wait for the biopsy. You can start the empirical radiation therapy to retrieve, to relieve the symptom. Now it's sorry, very careful saying you must take the biopsy before start the treatment. The line of treatment will be different, right? From the radiation chemosensitivities or tumor also. You differentiate the so research. There were 8 stage 3 or 4 months of first we do the medicine treatment, the stenting, then once the specific subsides, then we proceed for the biopsy, then start the treatment of the family. Your point very एकदम clear observation. Next, regarding the types of the endovascular treatment. Yesterday we did not about five like we estimated the balloon type of the steady. There was a balloon there. That is not very much good enough training. So far, I know the balloon type is still the max diameter is 6 cm. Now, after the length of the sphincter is 6 cm. If we go beyond 6 cm, there's some 7 cm what you're looking at. One cause, the balloon these stems are very prone towards the migration. For these two purposes, it's better to use the self-metallic expanded cells and the supplies of this version almost times version. That's very good. And there was that next step was that I don't know what's the price of that, but we should start with that. For that, still we didn't have the problem. But quite different cables and we need to dilute first. Yeah. So I mean that's that. Also, so I don't think it's something with the doctor. So the next thing that we start with, we must have dilators. So by the nailing is 1 millimeter our guide but doesn't pass. Then what we do, or even it passes the stent minute pass. So we have to pre-dilate it. For that we need the balloon dilators. That is also important is we didn't have the study. Just to know something whether they are bringing up smart. They were the next thing we should start with the dilators are dilated, but the maximal dilator is suppose that we don't go beyond 14 mm dilators. Because they're not here, it may cause the rupture of the spirit. Sometimes even the injury pericardium, capillary, etc. To avoid that, we use the balloon dilator is similar. Then the third thing is that third thing the cannulation technique. So quite different games are when it was easier, but if it's why prefer if you have got a course, this is quite good for us outside. Yeah, independent of more than yeah, but back of video, we have but let's suppose the scenario. The tumor is extending to one of the immune beds. And then what you will do, all this you guide by this class. And the next step would be so for that we need the smear we can convert to the film. We convert to the ICB or the like this. So that from here with the calculation, from here to the calculation, from where we you smear like doing a basket, something else. Yeah, like we cast the and retrograding and what is it, our pull out there. Then push the stem through that. So to put the ambient nursing on 9%. The future that scenario will happen. With two marriages, the resume. The very important that we're always afraid of is the stent migration. The stent displacement. The stent migration were given. Just to be we are very today central working so you would very now racking from my saying you which is racket to go possible cheaper, and then went inside the SPC. That's not something that the person from the average how do you achieve? I contact was night, contact with the CMC, send it out the clear awareness, reluctant. Then we did ourselves, we did surgery, we opened it, and then we retrieved, we make a bend from you, and then shift the chip was just visual of the success. As well as retrieval design. So one of the countries the stent retrieval. Stent retrieval is where the magnet will retrieval for like play. Just get scientists what we can retrieve it, pull out the femoral method, they don't retrieve it back. Too many importance of it. Next point, quite surprising when you say reviewer of past. And not only apps of a possibility which I got was our life expectancy of the patient should be more than 3 months. 3 months when the more when there is any benefit from the stenting, always no benefit. Right? Now let's suppose we did the stenting. Now patient is cured of the disease. Stomach compression was there. Patient is cured, the SVC has expanded. There's high likelihood the stent. Then we have to retrieve it. Keep on the lectures and we'll say it. We will palliative setting myself life of patient will be power of the listed drivers and answer. Third, now the patient is cured. Lymphoma zero, especially zero, that chemotherapy from disease is cured. So it's not, I think logically there may not be any benefit to keep the patient stay beside the retrieve. So you probably analyze it as a retrieve after conversation besides the last sentence very well. There are certain indications for the surgical intervention also. One is the failure, the stent despite or couldn't pass the stent, I know, or the quite visit the palliative setting, or the most important thing is thigh movement. Locally, tumor which is non-responsive to chemotherapy or radiation therapy, or despite chemo radiation, still got the state and the surgical resection and block with the SBC or immunotherapy is possible, then we get excited and bypass it. This is the one of those. So far, what is under duita garyasa for the mediastinal tumor, which has invaded the spirit and with the SBC obstruction. And two cases, the SBC excited the so very good. I think I would get start future also. Especially. Thank you very much. Reju Pasale case one sir. You say exactly listening इसको मेजर करने को सही मेजर हमने पहिले डिवाइडेशनले लॉक हुआ के पेन ड्राइव आपले खोलेर हेरे तिम्रो त के यहाँ पे यो कति दिन किनभने सिटी क्वाइट नट फ्यामिलियरिटी मलाई डाउट के थियो भने इफ इट इज इन्ट्रिङ डिसाइड राइट एट that would migrate, right? मलाई त्यस्तो लाग्छ फेरि त्यस्तो अझै रिभ्यू गर्नु लाग्छ मलाई नाच्न लाग्छ इट सुड रिमेन इनसाइड द स्पेसिफिक नट क्रस इन्टु लाइक द्याट maybe changing the right the sorts of makes but not really CT scan clear thing there I think is see the actual sensor was normal the stenosis type manager centimeter length now like 8 centimeter the body here because त्यो भएर अर्को एउटा चाहिँ हामीले हिजो गर्नुपर्ने थियो कि हामीले हप्तामा कहिले सुरुमै डाइ राम्ररी हाल्नु पर्थ्यो तर सुरुमै नहाल्नुले क्याथेटर राख्नु स्टेट हाल्नुभन्दा अगाडि क्याथेटर डाइ हाल्नु एक्सपोज गरेर कुन ठाउँमा स्ट्रक्चर छ पिन पोइन्ट त्यहाँ देख्नु पर्थ्यो पहिला ताकि हामीले सिटीबाट मेजर गर्थ्यो त्यहाँ भर्चुअली Anyway, thank you, Guru.
So kung भाइ आउनुभएको छ follow-up समस्या के छ
Yes, sir.